Good afternoon. When Chris and Marcus sent me the preliminary program some months ago, I was both excited and terrified to see my name assigned to this talk on sensation preservation, because I believe it is indeed the next level in breast reconstruction. Just when I thought I was doing a pretty good job with the cosmetic outcome, now where has this come from, right? So this is my confession part, other than which I have no disclosures. But then I decided to take on the challenge, and when I started thinking and reading about it, I realized that my mind had actually been preoccupied with this topic for some time now. Well, being a female plastic surgeon and running an exclusive women's health practice, I should probably be the last one to say, oh well, breast sensation is overrated anyway. Because indeed, when you think about the surface area that breasts occupy on a woman's body, it's quite huge, and not being able to feel this big an area of skin envelope is a major blow to the sense of wholeness. Furthermore, sensation is a part of body image, which is a multifactorial entity, and it has always amazed me to see the variations in individual women's perception of their breast sensitivity, not to mention the nipple areola, which is a totally unique feature of each individual's breast. And again, protective sensation, we are familiar with the attenuated sensation in patients with breast hypertrophy, often leading to even disruption of skin unity. And this is another extreme example I've seen in my residency years, whose static breasts caught on fire on stove while she was cooking because she did not have any protective sensation in the lower pole. Erogenous sensation, on the other hand, is certainly too complicated, if not overrated. So we have a long way to go with that part. So during the ongoing era of de-escalation in breast surgery, we've come a long way from crippling results to state-of-the-art reconstructions, preserving and reconstituting breast landmarks. And finally, we are ready to talk about sensory innervation too, which is the indispensable, inevitable topping of the ultimate outcome. When we talk about breast sensation after mastectomy, we can think of it in two terms. One is preservation of sensation, although despite obviously being the ideal scenario, it's not always possible. And the other is the return of sensation. And in the past, we did nothing for this part, but wait for spontaneous recovery. Until recently, there are exciting ongoing efforts about neurotisation, not only with autologous reconstruction, but also with implant reconstruction as well. Doctors Ann and Ziv Pellet have published their preliminary results in 2019, where they introduced immediate nipple neurotization by allografting the transected T3, T4 intercostals to the subareolar nerves. And early results are quite promising, with almost total preservation of sensation in both the breast skin as well as the nipple. So if we go back to the anatomy, the origins of the sensory distribution to the breast are from the lateral and anterior cutaneous branches of the 2nd to 6th intercostal nerves, with contributions from the supraclavicular. And the nipple sensation, on the other hand, is predominantly supplied by the lateral branch of the 4th intercostal, which we strive to preserve during mastectomy, although it's not the only nerve to reach the plexus under the areola, as sometimes claimed. Here you see red dashed lines demarcate the inferolateral breast quadrant to be avoided during surgical dissection to minimize loss of nipple sensation. And what is the actual data about sensory preservation? One of the earlier studies came from Sweden back in 1997, and they assessed touch sensibility in 80 breast cancer cases and compared them with healthy controls. They further grouped the patients according to the incision site as well as implant pocket, and what they found was that 1/3 of the patients had almost normal sensation, while only 14% lacked sensibility. Now, these numbers are far too optimistic from what we see every day in clinic, and I believe it boils down to the type of mastectomy back in the day, which was a subcutaneous mastectomy, the terminology referring to much thicker flaps, hence preserved sensation all the way from the beginning. In a more up-to-date study from the Netherlands, 51 women underwent unilateral mastectomy with or without implant reconstruction. Here it was found that even mastectomy alone caused a decrease in cutaneous protective sensation. However, after implant reconstruction, the sensation was completely lost in the majority of the breast. Even in risk-reducing cases, according to a more recent Swedish study with a fairly young group of women, breast sensibility is significantly impaired and the ability to experience sexual sensations in the breast is often lost. Furthermore, there is no difference in nipple sensitivity in a neck-sparing surgery as opposed to neck grafting. However hard we try to preserve vascularity, it obviously did not result in better nipple sensitivity. In 2016, a study from the UK showed better results in terms of sensory recovery in 181 breasts undergoing mastectomy recon for various reasons. Sensation was mostly preserved, although diminished in more than half of the cases. And they also compared their implant-only and implant with LD flap cases and could not detect any superiority of incorporating autologous tissue to the reconstruction in terms of sensation. Best recovery was found in the medial breast mound, similar to other reports in the literature. And interestingly, radiotherapy did not affect their results, which is, again, a controversial parameter affecting sensory recovery. This is an interesting study comparing the sensory outcome after autologous versus implant reconstruction. The originality of the study is that the sensory evaluation is made upon the native breast skin, even in the flap group, since the skin island was either totally buried or limited to the areolar opening. And what they found was significantly better sensory recovery in the implant group as opposed to flaps. And they attributed this to the fact that skin sensation recovery is more dependent on sprouting from the sides and independent of the reconstruction type. Another study came this year from Korea, where different reconstructive techniques were compared in detail, and for the first time, pre-pec versus partial retro-pec techniques were evaluated for their effects on sensory recovery. In this study, the IP flap group actually did better than implants, but there was no difference between pre-pec versus dual plane retro-pec in the implant group itself. So elevating some of the pectoralis, extending it with ADM did not attenuate sensory recovery. And this is no surprise because when you look at the old submuscular pocket technique, what really damages the lateral nerves is us, the reconstructive surgeon, inevitably transecting them while recruiting some serratus muscle to cover the lateral portion of the implant. While in the ADM-assisted dual plane and total pre-pec as well, obviously, the lateral portion of the chest wall is left intact and supported by ADM. So if the nerves are not damaged by mastectomy, we certainly don't damage them during the preparation of either dual plane or pre-pec pockets. So we recently started evaluating sensory return in our implant reconstructions, initially with a very select group of 34 patients, mostly DTI, 12 dual, 22 pre-pec, with an average time of 2 years between the last operation and sensory measurement. The study was restricted to unilateral cases because we wanted to compare the sensory thresholds with the healthy sides of the same patient, since sensory perception varies with each individual. So we divided the breast into 4 quadrants, used Sams-Weinstein monofilament tests, and matched the 2 groups for age, BMI, number of operations, time interval, and quality of life scores. Now, the only exception was the implant volume. It was found to be higher in the dual plane group, and this is probably because initially in the learning curve, only small to moderate sized breasts were chosen for pre-pec reconstruction. So the sensory thresholds in all sites were significantly higher in the reconstructed breast compared to the healthy side, and no significant difference was found between pre-pec versus the dual plane groups. In all operated breasts, pre-pec or dual, sensation was significantly better in the medial than the lateral half of the breast, and no difference was found, however, between the cranial or the caudal parts. In the pre-pec group, we interestingly found higher threshold values in the upper outer quadrant than the upper inner quadrant of the breast. In the dual plane technique, however, there was no such difference. Quality of life score surveys were again showing inverse relation with the threshold values. We also started collecting first year MRIs to compare the tissue thickness over the implant for further correlation with sensory preservation as well as recovery. And we are beginning to gather more data on that. So as we are expanding our pool of retrospective patient evaluation, we have also started recruiting patients for early postoperative sensory measurements at 6 weeks to better identify the techniques that serve to preserve sensation in the first place. MRI correlation, as I said, will be an ongoing part of the investigation, and evaluating the effects of both post-mastectomy and prior radiotherapy on sensory recovery will be introduced as well. And we are planning to dig deeper in the pre-pack group, investigating the effect of implant weight, surface type, as well as the type of soft tissue support used. And from clinical experience, our prediction is that sensory preservation is better with less manipulated pre-pack pocket, but this deteriorates over time with constant pressure on the skin envelope unless the implant weight is well supported. Hence, long-term recovery is expected to be, and actually is better in the dual plane technique, at least in our hands, with partial muscle support, not disrupting the sensory innervation and bearing the implant weight. Thank you.